Good morning, everyone. Today we will discuss about cirrhosis of liver. So, what is cirrhosis of liver? It is a end stage liver disease and a diffuse liver disease characterized by fibrosis and conversion of normal liver architecture into abnormal nodules. That is, a normal smooth structure of the liver surface is totally lost and the liver is becoming nodular in appearance. So the architecture of the liver is completely lost. So now it has come to an end stage of liver disease. So it is a irreversible damage. We cannot medically treat this condition and we cannot bring the liver to normal structure. It is classified into various types based on, first we will see morphological classification. In morphological classification, first we have to see about micronodular cirrhosis. As the term indicates, it is small nodules, micronodular. That is small uniform nodules, 3 millimeters in diameter. So the diameter of the each nodule should be less than 3 millimeter in size. These micronodules are about 1 lobule in size. So each and every lobule becomes 1 nodule size. And there is lack of normal lobular architecture. So if you see microscopically, the architecture of the cell is completely lost. So it totally looks abnormal. Okay. Now the nodules are separated by a thick regular septae. And all the nodules are affected nodules only. There are nothing normal. So all these are damaged cells. Now we go into examples of micronodular cirrhosis. So what are the things that causes micronodular cirrhosis? Now we have given here in the slide galactosemia, hemochromatosis, alcohol cirrhosis in the adults. Next, macronodular cirrhosis. These are large nodules, multilobular, post-hepatic, hepatitic, and post-necrotic and irregular cirrhosis. This is characterized by nodules of varying sizes, microscopic size up to 5 centimeter in diameter can be seen. These nodules are separated by irregular septae of varying sizes. Larger nodules may contain both portal triads and efferent veins, but their orientation to each other varies. They may contain both portal triads and veins, everything, but the orientation is not correct. It is abnormal. The liver may be shrunken and deformed. Most of the liver in cirrhosis is shrunken, that is, size of the liver is reduced and the surface is deformed. The normal structure is lost. That is called cirrhosis. Examples of macronodular cirrhosis: chronic active hepatitis due to hepatitis B or hepatitis C. Next is Wilson's disease. Another one is alpha-1 antitrypsin deficiency. Third type, that is mixed cirrhosis. These patients have features of both types of cirrhosis. That is, the first two types is seen in mixed cirrhosis, both the macro and micronodular cirrhosis. And another point is this micronodular cirrhosis can evolve into macronodular or mixed cirrhosis. So micronodular may change into second type or third type. Next is histological classification. How it is classified based on the histology. First one is post-necrotic cirrhosis, post-hepatic or irregular cirrhosis. It is due to the piecemeal necrosis that results in macronodular cirrhosis and can be seen in viral hepatitis, neonatal hepatitis, autoimmune hepatitis, drug-induced hepatitis. So what are the drugs causing hepatitis? One is INH, next one is methyl dopa. These two drugs may lead to post-necrotic cirrhosis. So in cases of chronic viral hepatitis, neonatal hepatitis, autoimmune hepatitis, and drug-induced hepatitis, we are seen in post-necrotic cirrhosis. This can be seen in children with biliary atresia, Bailer's disease, and cystic fibrosis. In adults, it is seen in Anand cirrhosis, that is primary biliary cirrhosis, gallstone disease, bile duct and pancreatic tumors resulting in biliary obstruction, that is periportal or biliary cirrhosis. This is type B. Okay. Type C is cardiac cirrhosis. In cardiac cirrhosis, the hepatocellular necrosis leads to the formation of fibrous bridges between the central veins. Examples are chronic congestive cardiac failure, cardiomyopathy, constrictive pericarditis, veno-occlusive disease, Budd-Chiari syndrome. Next one is type D. These are called miscellaneous cirrhosis. Next to cardiac cirrhosis, we have miscellaneous cirrhosis, that is pigment cirrhosis, Wilson's disease, and hemochromatosis, alpha-1 antitrypsin deficiency. Next one is clinical classification of cirrhosis. Based on clinical presentation, cirrhosis can be classified into two types, that is compensated or latent or inactive cirrhosis. Second type is decompensated or active cirrhosis. So what is compensated and what is decompensated? In compensated cirrhosis, there is no clinical features suggestive of liver failure or cirrhosis. The patient looks normal. The patient is looking normal. He doesn't come for any medical treatment. The next stage is the same liver becomes decompensated. It cannot compensate anymore. So the patient becomes clinically active. Now he is having all the features of cirrhosis, jaundice, and liver failure. This is where he comes to the hospital for treatment. Next one is fourth type, that is etiological classification. Based on the etiology of the disease, we can classify the cirrhosis into various types. First one is cirrhosis in infants. First cause is extrahepatic biliary atresia. In infants, one main cause is extrahepatic biliary atresia. So any child with jaundice, we always rule out extrahepatic biliary atresia. Next is severe neonatal hepatitis. So in post newborn period, that is after delivery, neonatal period, first 27 days, the child may develop hepatitis due to viral infection. The virus may be transmitted from mother to the baby. So the child's developing hepatitis. Next one is galactosemia type 1, tyrosinemia, neonatal hemochromatosis. Now next we go to cirrhosis in older children. So what is the first one? First one is infective cause. This is most common type in our part of the world. In India, we see infective causes in most of the case. So first one is viral hepatitis. So viral hepatitis is very common in India. First one is hepatitis B, hepatitis D, and hepatitis C. The next virus is cytomegalovirus. It is one of the largest virus, known virus, that is cytomegalovirus, that affects the human beings. Next one is herpes simplex. Last one is rubella infection. These are the infective causes of cirrhosis in older children. First one is viral hepatitis B, D, and C, cytomegalovirus, herpes virus, and rubella virus. Next is genetic or metabolic causes. So after ruling out infective causes, if you are not able to make a diagnosis, look for genetic cause or metabolic cause. The disorder of carbohydrate metabolism. First to start with carbohydrate metabolism, galactosemia, hereditary fructose intolerance, Anderson disease, and Cory's disease. Disorders of protein metabolism. Here you have type 1 hereditary tyrosinemia, urea cycle disorders, disorders of lipid metabolism. Next one is disorders of lipid metabolism, Gaucher's disease, Niemann-Pick's disease, Ullmann's disease. Metal storage disorders. In metal storage disorders, you have Wilson's disease. It is copper metabolism. There is an abnormal metabolism of copper in the body. So excess copper gets deposited in the tissues like liver, brain, and kidney. So it may lead to liver damage and necrosis of the cells, leading to cirrhosis and fibrosis. Next one is neonatal hemochromatosis. Paroxysmal disorders. Examples are 1. Zellweger's syndrome. There is only one example, that is Zellweger's syndrome. Next one is miscellaneous causes. In miscellaneous causes, we have cystic fibrosis, Langerhans cell histiocytosis, and last one is alpha-1 antitrypsin deficiency. This comes in the miscellaneous types. Now next we go to biliary cirrhosis. In biliary cirrhosis, we have extrahepatic biliary atresia, intrahepatic biliary hypoplasia, choledochal cyst, choledocholithiasis, Bailer's disease, Watson-Allegili syndromes, and primary sclerosing cholangitis. Drug-induced cirrhosis. Drug-induced cirrhosis, we have 4 common drugs: methyl dopa, INH, methotrexate, and nitrofurantoin. These 4 drugs may lead to cirrhosis of the liver. That is methyl dopa, INH, methotrexate, and nitrofurantoin. Vascular causes of cirrhosis. It is constrictive pericarditis, Epstein's anomaly, chronic congestive cardiac failure, Budd-Chiari syndrome, veno-occlusive disease. These are the vascular causes of cirrhosis. Miscellaneous causes. One is ulcerative colitis, Indian childhood cirrhosis, and last one is total parental nutrition. That is patients who have been admitted in the hospital for a very long time, who are not able to take food by mouth, oral diet. So they are on total parental nutrition for a very long time. So ulcerative colitis, Indian childhood cirrhosis, and total parental nutrition. Now we go into the clinical features of cirrhosis. So what are the clinical features of cirrhosis? So on examining a child, you have to look for striae. You have to seen for the skin. Examine the child. You have to ask the child to remove the dress and look for striae on the skin or the trunk. Next is acne. You can see acne on the face. Next one is KF ring. KF ring is to see in the eyes, in the cornea. You have to examine with the slit lamp examination. You have to do. This is to rule out copper deposition. Next one is sunflower cataract. Next is blue lanulae of the nails, recurrent respiratory tract infections, pancreatic insufficiency, and next one is biliary obstruction. In case of biliary obstruction, the patient will come with pruritus, pale stools, cholestatic jaundice, xanthelisma, malabsorption symptoms, deficiency of fat soluble vitamins. Next, you look for skin changes, that is vascular spiders. One is palmar erythema, next one is malar erythema. Palmar erythema you have to see in the hands of the patient. Malar erythema, you look for the malar prominence. So first one is striae, next acne, KF ring, sunflower cataracts, blue lanulae of the nails, recurrent respiratory tract infections, pancreatic insufficiency, pruritus, hair stools, cholestatic jaundice, xanthelisma, malabsorption, deficiency of fat soluble vitamins. Next to look for skin changes, that is vascular spiders, palmar erythema and malar erythema. So these are the clinical features of cirrhosis. Next we go to nail changes. First one is clubbing, next is leukonychia, next is mucous line, terrace nail and blue lanulae. These are the nail changes you see in case of cirrhosis. Clubbing, you have to elicit clubbing. So after clinical examination and history taking, now you have to come to a conclusion. The child is having some liver disease. So now you have to prove your diagnosis. So what are the investigations you are going to do for proving your diagnosis that this child is having cirrhosis? First is we have to do a liver function test. So in liver function test, you do bilirubin and liver enzymes. Next we go to prothrombin time. So in case of liver disease, there is prolongation of the bleeding time and clotting time. So we have to check the prothrombin time. So most of them presents with bleeding disorders. Next one is test for infections. Test for viral infections. You have to check for hepatitis B and D and C. Test for metabolic liver disease. Now if you rule out infection, next you have to check for metabolic liver diseases. So what are the causes of metabolic liver disease? You have carbohydrate disorders, protein disorders and fat metabolic disorders and metal deposit on the liver. So for each and everything you have to rule out. So you have to do specific test for diagnosing those disease based on the clinical presentation. Next you do autoimmune hepatitis, auto antibodies. You have to look in your patient. Next one is ultrasonography. You have to do an ultrasound scan and you have to see the surface of the liver, size of the liver, look for the gallbladder, look for gallstones, look for atresia. Okay, there is atresia of the gallbladder. Next you go for liver biopsy. If cirrhosis is confirmed by ultrasound, now we can do liver biopsy and you can see what type of liver cirrhosis is present in this particular patient. So what are the complications of cirrhosis? First one is portal hypertension. So patient will have increased pressure in the portal system. From low pressure system, it becomes an hypertension. So in case of hypertension, there is GI bleeding for the patient. Next one is ascites. In case of cirrhosis and liver failure, there is hypoproteinemia. So patient develops a massive ascites. After ascites, there is spontaneous bacterial peritonitis because the immune system is not properly functioning because of hypoproteinemia. The globulins are not secreted properly, so there is loss of immunoglobulins. So the immune system is not working properly. So this bacterial peritonitis is very common. Next one is encephalopathy. Next one is coagulopathy, hypersplenism, which may cause pancytopenia. So size of the spleen is increased. This child will have a massive splenomegaly. Due to massive splenomegaly, there is pancytopenia. Due to coagulopathy, there may be bleeding. Due to encephalopathy, child may have loss of consciousness. Next one is delayed puberty. Because of liver failure, there is delayed puberty, and hepatocellular carcinoma may come after cirrhosis of liver, especially after hepatitis B infection and C infection. Next most common thing is hemochromatosis, and last one is hepatorenal syndrome. These are the complications of cirrhosis. First one is portal hypertension, GI bleed, ascites, spontaneous bacterial peritonitis, encephalopathy, coagulopathy, hypersplenism leading to pancytopenia, delayed puberty, hepatocellular carcinoma, hepatorenal syndrome. These are the complications of cirrhosis. Now we will see about hepatorenal syndrome. What is hepatorenal syndrome? That is, in case of liver failure, the patient will slowly go into renal failure. Over a period of time, the patient slowly goes into renal failure, and at one point you will have both renal failure and liver failure. Okay, what are the reasons for this hepatorenal syndrome? First is renal cortical vasoconstriction. So there is renal cortical vasoconstriction. This may be due to increased renin release and increased synthesis of angiotensin II. So there is an increased renin release and increased synthesis of angiotensin II. The decreased renal synthesis of vasodilator prostaglandins like PGI2 and PGE2. Next reason on the increased production of vasoconstrictor prostaglandins like thromboxane A2 may also contribute to renal cortical vasoconstriction. The first one is renal cortical vasoconstriction due to increased renin release and increased synthesis of angiotensin II. Second is decreased renal synthesis of vasodilator prostaglandin like PGI2 and PGE2. Third is increased production of vasoconstrictor prostaglandins like thromboxane A2 may also contribute to renal cortical vasoconstriction. So this leads to reduced effective renal circulation and reduced effective plasma volume. So the renal circulation is reduced. Hepatorenal syndrome is precipitated by the following disease. One is diarrhea. Second one is vigorous diuretic therapy and injudicious paracentesis and prolonged GI bleeding. So in patients with cirrhosis having diarrhea and taking too much of diuretics and doing paracentesis and removing a large quantity of fluid from the ascites, and in case of upper GI bleed, this may precipitate the HRS. So what are the urine findings? The urine analysis is usually normal. In HRS it is normal. Urine sodium is typically less than 10 milliequivalents per liter, and the urine osmolality is 100 milliosmoles higher than that of serum value. The ratio of urinary creatinine to serum creatinine is greater than 30. So this is the end of cirrhosis liver. So here we have seen about what is cirrhosis. Cirrhosis is damage of the hepatic tissues. Okay, this may be classified into various types. One is micronodular cirrhosis. Next one is macronodular cirrhosis. Next is mixed cirrhosis, where you can see both micronodules and macronodules. Histological classification. Here we divide into histological classification. First one is post-necrotic cirrhosis. Second one is periportal or biliary cirrhosis. Third one is cardiac cirrhosis. Next is etiological classification. In between you have clinical classification, that is compensated or decompensated. Based on etiology, you have cirrhosis of infants and cirrhosis in older children. So these two are two different issues. In infants and newborns, you always think about congenital anomalies or infection transmitted from mother or metabolic disorders. These are very common in newborns. Next one is cirrhosis in older children. The most common is infective cause. If it is not fitting into infective cause, go into genetic or metabolic cause. Okay. Then go to metal storage disorder, Wilson's disease. This is another one common disorder we find in our part of the world, Wilson's disease. Drug-induced cirrhosis, mostly seen in methyl dopa, INH, methotrexate and nitrofurantoin. Vascular cirrhosis. Then clinical features. Should be able to tell all the clinical features of liver failure and cirrhosis. These are the following clinical features. These are the nail changes. Clubbing is one important nail change you see in case of liver failure. Always examine the palms and nails in case of liver failure. Now you have investigations. How will you investigate a patient? First you have to order for a liver function test. You have to see for abnormal liver enzymes, proteins and bilirubin. So child may have jaundice. Next is for bleeding disorders. You have to estimate the prothrombin time. Next you will look for infection, then metabolic disorders, autoimmune hepatitis, then ultrasonography and the liver biopsy. Next is complications. What are the complications you will see in cirrhosis? One is portal hypertension, GI bleed, ascites, peritonitis, encephalopathy, coagulopathy, hyposplenism, delayed puberty, hepatocellular carcinoma. A long term in the post-infective cases like hepatitis B and C, patient may develop hepatocellular carcinoma. Last one is hepatorenal syndrome. Hepatorenal syndrome, there is because of vasoconstriction. Okay, there is vasoconstriction inside the kidney because of this renin and prostaglandin thromboxane. So they reduce the renal circulation and reduce the effective plasma volume. So all these conditions will lead to precipitating of HRS, that is diarrhea, vigorous diuretic therapy, injudicious pancreas paracentesis, and GI bleeding. Now we have urine findings. Thank you. This is the end of the session.